Hello and welcome to Fairwinds Medical Healthcare Unscripted podcast. I'm your host, Dr. Chris Hussey, orthopedic surgeon practicing in Texas and Mississippi. We are honored and thankful today to have Dr. Brian Polsky, who's an orthopedic surgeon practicing in the Baltimore, Washington area. Welcome, Brian. We're pleased to have you.
Thank you.
Please tell us a little bit about yourself and your practice, and then we'll go into a little bit about your training.
Sure. First of all, Chris and Holden, thank you for having me. I've been looking forward to this. I'm in private practice. I started in 2001 in the Baltimore, Washington area. I actually grew up in the area, so I was raised in Columbia, Maryland, which is a kind of halfway between Baltimore and Washington. I went to South Carolina for undergraduate and medical school, and then went up to Philadelphia to do my surgical training and my fellowship at Temple and University of Pennsylvania. And then I came back to this area to practice. It's interesting because I didn't realize it when it happened, but I came back to practice with a private practice group, and one of the gentlemen in the group, who was one of the more senior gentlemen, reminded me that I think about 5 or 8 years prior he had operated on my sister. So I didn't even realize it until I joined the group that we actually have frequented that group before, my family.
Oh, that's terrific. That's a great story.
Yeah, it was fun.
Great story.
And he's a close friend, still practices.
Oh, wow. Okay. Very good. Very
So,
good. So tell me a little bit about your Baltimore and your fellowship experience.
I did my fellowship in Philadelphia at University of Pennsylvania. I did my fellowship in essentially sports injuries and arthritis. So, that was essentially arthroscopic surgery as well as joint replacement surgery. And so I was fortunate enough to spend actually 2 seasons and 2 summer camps taking care of the Philadelphia Eagles, which was
Wow.
a lot of fun.
Wow.
Yep, very
Yeah.
fascinating. Andy Reid was the coach. So
Right.
2000, 2001, and actually lived at the summer camp for 2 summers. I was the only physician there taking care of the team. A wonderful experience I had at University of Pennsylvania, taking care of patients and just, high volume arthroscopic practice, and then doing lots of joint replacements as well.
That's a terrific combination. What percentage would you say of your practice is scopes versus replacement arthroplasty?
Great question. And it's actually evolved. When I started, it was almost all athletes and younger folks, and, a lot of arthroscopic procedures, shoulders, hips, knees. Hips was very low on the list in the very beginning of my practice, but mainly shoulders and knees. I used to do a lot of wrist arthroscopy and ankle arthroscopy. And then interestingly, as my practice evolved and I was fortunate enough to take care of these people more long-term and more members of their family, I started getting more of the more mature population
Sure.
and their joints, and that turned more into joint replacements. And so it kind of flips halfway through your practice, and now it's probably almost half and half, probably half joints, half scopes. Yeah.
It is interesting how that does evolve over time because, you start out with the younger sports medicine scope practice, and the natural evolution is they age, you get their parents because they trust you.
Right.
So I think that's terrific. Now, you're part of a larger group?
Right. So that's another interesting story. So when I joined my private practice group in 2001, we were 6 people, 6-person private practice group. They had actually been around a long time, since the late 60s, early 70s. And then our group slowly grew over the years to about a dozen. Then we got to be 13 and 14. And at that point, there was a move to consolidate private practice groups. And we actually tried that like 15 years ago, and it didn't work. It was like herding cats. Everyone wanted to do something different and blah, blah, blah. No one could agree on anything.
Sure.
And so we stopped. It was something that everybody wanted to do. It just was difficult to get it done. So we never really stopped thinking about it. And about 5 to 8 years later, it ended up happening. And so we developed essentially a mega group called the Centers of Advanced Orthopedics, which is now, I believe, over 180 orthopedic surgeons, the largest private practice group in the country.
Wow. That's terrific. So is most of your practice surgery center based or hospital based?
That's also an evolution. In the way back, there were no surgical centers. In 2001, or at least we didn't have any. It was a very minor thing. And then over the years, that's developed. more recently with the advent of doing joint replacements outpatient, spine surgery outpatient, that's become a much bigger thing. So at this point, probably 75% of what I do is at ambulatory surgical centers.
Wow.
And then probably, maybe a quarter, maybe up to a third at hospitals for either sicker patients that can't be done outpatient, or some of those hospitals that I work at, it's a lot less expensive for their employees to have their procedures done there than to have them done at an ambulatory surgical center. So there's some reasons.
Wow, that's very interesting. It makes sense. I never thought of it that way before, but very interesting. So I know that you are very interested in teaching. So do you have a residency program that flows through your all's practice?
So we currently don't. I was very fortunate. Pretty much in the beginning, I started when I was, even before I was a partner, we worked at a hospital called Kernan Hospital, which was essentially a teaching hospital of University of Maryland. And so in the very beginning, I actually, a couple years into my practice, I was teaching residents. And it was kind of thrust upon me, but I really enjoyed it. The interaction and the teaching and being able to have the opportunity to work with these younger surgeons was wonderful. And I did that for a few years, and then it kind of faded away for a couple reasons. The residents didn't rotate at that hospital as much. And then for better or for worse, in private practice, I mean, I do between 500 and 600 cases a year.
Wow, that's big practice.
Yeah, so, on a day, if I have 8 cases, it's kind of difficult to teach. I'm running 2 rooms, going back and forth. And so recently I haven't taught as much. I do have a lot of med students and other students shadowing me for sometimes weeks at a time in the office, and I'll bring them into the OR, but I haven't been able to do as much formal teaching. My hope is that that'll change in the not too distant future.
Well, I agree. Having done a fair amount of teaching myself, it's very enjoyable, and I do enjoy that interaction. It does slow you down, and so if you've got a busy private practice and you're doing that many cases, it delays your day. It's a double-edged sword. You love the interaction, you love the teaching, but also you got to make a living. I'm impressed, and I'm glad that you're still able to do that, and I know that the residents benefit from following you, especially, and we're going to delve into this a little bit more later. You do some procedures that a lot of orthopedic surgeons don't do. Specifically, I'm talking about hip arthroscopy.
Right.
And so I'm assuming that when they come into your OR, they've just never seen it before.
That's been a very interesting aspect of my practice, and I covet it. I love it. I enjoy it. It's very challenging. But even the story is interesting. So in my fellowship, which I was, again, specialized in arthroscopic surgery and joint replacements, I did a sum total of 1 hip arthroscopy in my entire fellowship.
Wow.
Even back in 2000, 2001, it was not a common procedure.
No, it wasn't at all. Still isn't. Still isn't.
Exactly. And back then, obviously, it was a rarity. I mean, like, very few people did it. And even the techniques and the instruments and stuff were nowhere near what they are today. So I get into private practice and I dabble in it. I did a couple of like loose body removals, something that you can kind of get in there and do and get out. One of my partners was a very, very skilled arthroscopist and more of a senior practicing guy. And he actually flew out to Colorado and did kind of a mini fellowship with Dr. Philippon, he's kind of the guru of hip arthroscopy.
Right.
And then he came back and subsequently ended up having very badly arthritic CMC joints a few years later and had to stop operating.
Oh, gosh.
So he came to me and said, "Hey, Brian, are you interested in hip arthroscopy and kind of taking over this aspect of what I do?" And I said, "Sure, let's do it." So I spent a month with him and learning his technique, and that's kind of how I did my own mini fellowship and got more into hip arthroscopy.
What a fortunate turn of events. I mean, I'm sorry for him and his health, but for you and again, I mean, there just aren't a lot of I'll say hip arthroscopists out there. And again, I'm sure that the residents, they probably don't really appreciate how unusual that is, but the fact that they're able to see it. So tell me a little bit, I'm jumping a little bit ahead of myself here. Tell me a little bit about your actual hip scope technique.
Sure. So that's an evolution too. I mean, when we started 15 years ago, we actually did not have hip length arthroscopes. So we used shoulder and knee arthroscopes
Right.
and struggled because it was short and the physics of it was different. Hip arthroscopy is very challenging because it's a very tight envelope. It's very deep. The anatomy is very, very variable. And the angles are not simple, like trying to get arthroscopic portals established. You have to perform what's called a capsulotomy so that you can open the hip a little bit to get a little more flexibility in there. So over time, I developed essentially a two-portal technique where I use just two portals, and I can essentially do everything through those. I do an interportal capsulotomy, so I do a smaller capsulotomy just between the portals so that I can, reconstruct or repair labrum. And then in folks that have bony abnormalities like either pincer lesions on the acetabular side or a cam deformity on the femoral side, I can take care of the bony abnormalities through the same portals.
Wow.
It's even a little bit less invasive that way. And then the other thing that developed over the years is it does appear as if repairing the capsule is very, very important because we used to actually not do that.
I was just going to ask you about that. How do you do that? But go ahead.
That's a good question. And there's still some black boxes in hip arthroscopy. That's one of them, and it's simply you got to kind of struggle to get sutures in. I mean, having done a lot of them, it's not as much of a struggle, but, it's not an easy thing to get sutures through the capsule and then you have to tie them essentially blindly down the portal, in a surgeon's knot technique to bring the capsule back together. But it's very important to reconstruct that because it can be as bad as having instability, if you don't typically repair that. Yeah.
Of course. I think the common expectation of most orthopedic surgeons is that you just do labral work, but you don't. You also do bony work.
Yeah, that's a good question. And I would say the evolution of that also has changed. In other words, I kind of call it like hidden bony abnormalities. I mean, it's more common in males. So males much more commonly have cam impingement. Females can have pincer type impingement. I'm doing bony work in 2/3 of patients. I mean, it's a lot, where it used to be the opposite. And so you have to be carefully put the hip through a range of motion to prove that there's no impingement after you do a labral reconstruction or repair, and take care of anything that's impinging. Some of it's obvious on x-ray and that you take care of much more easily, but sometimes you can have impingement type anatomy that you only discover intraoperatively during range of motion, which is just another aspect of the difficulty of hip arthroscopy.
That's really interesting. So a couple of questions here just on the basics of it. What type of table do you use?
So and there's a couple options for that. I mean, I'm still fairly classic in that I use traction. So I'll put the foot in almost a fracture table, and put a pad at the groin, and I will pull my own traction. It's the one procedure where I use general anesthesia with paralysis. So because
Interesting.
makes it much, much easier on me and the patient.
Sure. Of course.
And I've been fortunate enough to become pretty efficient at it. So my traction times are, 30, 35, 40 minutes at the most. And that's important actually, because you can have very significant pudendal nerve injuries. If there are some folks that dabble in that hip for hours at a time, it's very bad. You can't do that.
Absolutely. I've observed several hip scopes, and the ones I have watched have not been done on a fracture table, and getting distraction of the joint for the surgeons that I was observing was really, really difficult. There's just not much room there to begin with.
Correct.
And then if you don't have the traction on it to give you more of a gap, obviously, unlike most orthopedic surgeons, knees and shoulders, do you find when you get into a hip scope sometimes that the bony abnormalities were much more than you expected because you really can't see that other side until you're actually in there with the scope?
Yeah.
Can't count how many knees I've scoped, and afterwards in the recovery room, I've talked to the patient and family saying, "You just need a new knee."
Yeah.
And I assume that happens with hips as well.
It does. It does happen, and like you said, it probably happens more than I'd like to. I don't know about admit is the right word, but yeah, I mean, more so than you think. Even with MRI, even with experience, you have to be prepared kind of for everything. I'll tell you The difficult thing in hip arthroscopy is when labral tears are not in classic areas. Like, fortunately, 90+% of the time, it's an anterior labral tear. That's just the anatomy, it's the physics, it's the mechanism, and that's almost always where they are, which is great because I'm very good at that. But if there's a, if
It's right there.
it's right there, and I do a lot of those, and that's fine. But if there's a labral tear that extends laterally around the exterior lateral portion of the acetabulum, that's tough. And as a matter of fact, I have a famous story that I tell residents and stuff, is that, doing a lateral labral repair takes a lot of patience. It takes really good angles and really good portal placement. I had one where I was in there and I was trying to extend my capsulotomy, and I had a little stress on the beaver blade, and the blade broke off.
Yeah.
In the hip.
Oh.
Stuck in the hip.
Yeah.
That is a really, really bad feeling. And so
that's a bad day.
you stop, you get an x-ray, take your time. I was very fortunate. It took 45 minutes, but I got the blade out carefully, no problem, finished the procedure. But those are the kind of things that stick with you.
Sure.
Never, ever, ever go away. So I get little headaches and palpitations when I do lateral labral repairs. Yeah.
Sure. 100%. I totally get. Do you typically do an arthrogram before you do a hip scope?
No, I do not. That's a good, the MRIs are really good now, and I think between those, if someone's had previous surgery or there's some other, abnormality in there, I would consider doing that. Yes.
Okay.
But, first time, I typically don't.
Okay. And then postoperatively, what's the typical post-op recovery with regard to weight bearing, and do you typically do physical therapy, those types of things?
So that's changed as well. In the beginning, that was strict non-weight bearing with a repair, strict non-weight bearing, and we had these big hip braces that went around the waist and held the leg and this and that. And fortunately, I can't even remember at this point, someone did a really well-designed study that pretty much proved that the braces were worthless.
They're typically one size fits nobody, so it's never.
And those were all the phone calls I got. It's falling down. I have to come in. The brace, right? So thank goodness. And I pretty much expected that. I mean, the hip is a very stable joint. Even with a capsulotomy, even when we weren't doing the repairs, they're not coming out. Right. So no bracing now. I do full weight bearing. I have them use crutches for 2 weeks for kind of balance, because I just had a few people fall in the beginning of that. But those labral repairs are very robust, and as long as there's not any significant other abnormalities, I let them bear weight for the first 2 weeks carefully. I limit flexion past 90 degrees for 6 weeks, because that's an anterior repair. They start physical therapy 2 weeks after surgery. It's interesting that people feel good very quickly. What takes time is strength, flexibility, and stamina.
Right.
Because these are the folks that I get who have had hip pain for 6 years. They've been misdiagnosed. I had a groin pull for 4 years. This and that. And then they finally make it to me and they're diagnosed with a labral tear. The labral tear gets fixed and they feel better, but their muscles are really messed up.
Yeah, 100%. And then that's an uphill struggle of trying to rehab them, but also to regain strength, and because they've basically been immobile for a long, long time.
Yeah.
So that's very interesting.
Healthcare Unscripted is powered by Fairwinds Medical, the commercialization team behind some of the most innovative technologies entering operating rooms today. With national reach and clinical expertise, Fairwinds moves new solutions from promising to practice. Visit fairwindsmedical.com to learn more.
So the teaching aspect, you said that you typically have residents that come through?
I do, and I've had been fortunate enough to have some international and American, visiting physicians that want to come see the technique. I'll tell you that the biggest thing with hip arthroscopy is the setup. I mean, it has to be set up correctly. It has to be a good table. You have to have good traction. I mean, there's other, like you said, some of these folks are trying to do either tractionless or, I have a partner that does a couple hip scopes, and he uses a postless technique where there's this foam that supposedly the patient doesn't slide and you can pull on the leg. You have to have good traction or you can't do the procedure. I mean, it is what it is. And
Yeah.
I also think you have to be efficient.
True. I think it's one of the things that I'm certainly older than you, but I think it's one of those things that you learn over time is why make this harder? I mean, there's so many things, tips and tricks and
Sure.
techniques that you can do to make your day much better, but also a better outcome for the patient. And I
Agree.
just don't understand the whole concept of, I'm not going to do that, and it just makes the day harder. And honestly, I think it affects the outcomes.
Agree.
So I think that's really interesting that you're able to do that, especially the teaching part of it. I think that's really important. I mean, the residents benefit from seeing that. It may be something that they never ever do, but by the same token, they will have seen it. I didn't see a hip scope until I'd been in practice for 20 years.
Exactly. Exactly. Well, it also might spark an interest. If they see that, it might get fascinated and decide they want to do a fellowship where that's included. And, that's starting to be the case is there's some good sports fellowships that now do a lot of hip arthroscopy.
Interesting. Okay.
Yeah.
It makes sense. I had never thought of it that way before, but it does. I want to switch focus here a little bit because I know you're also very, very interested in and involved with designing. And what specifically are you focused on with regard to, I assume, surgical technique as well as equipment designing?
Yeah. I mean, I find what we do is fascinating. I've always enjoyed the physics of it and the math and the design. And, you know, most of us that I think do this, putting things together kind of speaks to us. And,
True.
the satisfaction of, I love fracture work. I just didn't want to take call. But I still do, like last week I did 2 clavicle fractures. It still jazzes me. I love it.
Yeah.
Especially, I mean, obviously a good outcome, but plates and screws and putting this together and that together. So for me, it was kind of natural that my brain went to, for whatever reason, how can this be done better? Or how can this implant be better? And even when I was a resident, I had thoughts like that about how can arthroscopy be better. So I've had opportunities over the decades to work with companies and design some implants, and I mean I even still work today with some companies currently on designing some hip arthroscopy implants and improving that, because I think there's a lot of room for that actually in hip arthroscopy. So mainly arthroscopic implant type stuff. I actually worked a little bit on a flexor tendon repair device that never actually came to market, but it was brilliant. And that was an Israeli company. So yeah, it's fun. I enjoy that. It's just another aspect of science and what I enjoy. If any of it makes life easier for orthopedic surgeons or better outcomes for patients, then
Right.
that's a bonus.
I agree. I've been fortunate enough to be in a couple of hip and knee arthroplasty design groups, and
Yeah,
it is very rewarding.
it is.
It's also really interesting to me because I remember the first one I was on, and then several since then. The smartest people in the room are the engineers.
Oh yeah,
They're, I mean, it's amazing,
yeah.
and I really didn't appreciate what they did. It was just one of those things where I finally figured out, Chris, just sit and be quiet. Just listen.
Yeah,
Yeah.
they'll ask me when they need something.
Exactly right.
Yeah. Yeah, no,
That's
I'm doing
terrific.
this hip implant that I'm doing now with this company. One of the founders and leads of the company is a mechanical engineer. And he's working with me on these implants, and the stuff he comes up with and the stuff he solves over a weekend is just
Yeah,
unbelievable.
it really is.
It's amazing. I
It,
love it.
they're fun to be around and to listen to. And
Yeah.
again, I think the nature of being an orthopedic surgeon is you're typically used to being in charge and taking control, and you lead the conversation.
Right.
One of the things that took me a while to figure out was, Chris, just stop talking.
Yeah.
Listen, and
Right.
it's amazing what you learn.
Yeah. Totally agree. Totally agree. And he came up with solutions, and I was like, that is really fantastic.
That's terrific.
Yeah.
So currently, what are you working on with regard to design?
So one of them is currently working on new hip implants for labral repair and technique. So the implant itself as well as the instrumentation, that, kind of a two-pronged. And then, the other thing I got involved with years ago was a company called Romtech, which is
Yeah, I'm
so
familiar with that.
Aria, yeah. And I'll tell you, I got involved with them, 7, 8, 9 years ago, and it's an amazing device. And I was the first one to use it on the entire Eastern Shore board, East Coast.
Wow.
And now everybody's using it. And I forgot the gentleman's name at WashU, very well-known orthopedic surgeon. It slips my mind right now, but he did a very good white paper that really proved improved range of motion, decreased pain, decreased swelling and stuff for knee replacements using the Romtech device. So I work with them. I do some other stuff too. Can't keep it all straight. I'm working with a company in Israel. It's actually a spine company that they asked me to help with, but it's more of a mapping technology for spine surgery. But they think, and I do too, that it could be useful for shoulder and knee surgery as well. That's kind of where I got involved.
Wow, that's interesting.
Yeah, so it's a computer program that predicts success or failure of spine implants.
Wow, that's
Fascinating.
phenomenal.
Very interesting, almost AI type, and they are actually starting to incorporate that. So for spine, it's important because the failure rates are so high, relatively speaking, that they can put in all this patient data, and it can really give you success and failure rates based on whatever you think the implants should be. It can even make suggestions for implants. Their hope is that it can make 3D printed implants that are the ones you use with the highest predictable success rate.
Wow, that's terrific. Now, do you do spine?
No. I run screaming from spine.
So it's interesting. I think I'm probably fairly typical. I was trained to do spine, one level, one side, very simple stuff. And I've been in practice maybe 3 or 4 years, and I got up one morning. I'm generally a pretty happy-go-lucky kind of guy. And I was driving to the hospital, and I was just in a terrible mood. Terrible. I was like, why are you so unhappy? It's because I had to do a laminectomy that day. And it was like, I hate this. That was the last lumbar surgery I ever did.
Yeah.
It's like, I do not need this in my life.
Right.
And I think that's a natural evolution for a lot of guys. If you want to do spine, you should go do a fellowship, first of all.
I agree. In this day and age.
Yeah, 100%. So I want to tilt back towards your sports medicine part. So that's a pretty significant part of your practice. And do you also do collegiate high school or just pro?
I take care of everybody, right? So in my private practice, it tends to be weekend warriors and high schools. I do get a lot of college athletes that either from the area or come home for college breaks that want to get things fixed or whatever. The pro stuff I've been consulted on for, the Ravens and some of the other teams, but I'm not the official physician. And actually, I learned pretty quickly into private practice that it was actually good not to be the official physician.
I'll make this observation just to see if you've had the same experience that I've had. I have found between my actual high school and college athletes as opposed to the weekend warrior is the most non-compliant patient that can take care of. I mean, it's like, but at least in the college, high school stuff, you at least have the coach on your side, and plus they want to get back and they want to get back as quick as they can. Whereas the weekend warrior is like, oh, well, I can go play, tag football this weekend. No, you can't.
Exactly. That's very accurate. All they have is themselves to blame, and that's usually enough.
Very interesting. Very interesting. So is there any other aspect of your practice? Again, the hip scope is unusual outside of most of our areas, but what other areas in your practice? I assume you do ACL. I'd like to know what technique and what graft you use.
So I've done. Yeah, I mean, ACLs is one of my favorite procedures. I do a lot.
It's my all-time favorite procedure.
Yeah, I love ACLs, and that's also evolved. I mean, when I started, it was all autograft, right? Almost all. Bone, patella tendon, bone, and that was the lion's share of what I did, and they did great. Okay, and then I fairly quickly, because actually one of my mentors actually used a lot of allograft, even back in the 2000, 2001. And so I pretty quickly started using a lot of allograft. Back then it was a Achilles allograft. So you'd have at least one end that was bony, and then you could customize the other end of it, and then we'd put that in and kind of fix it the same way with screws. It used to be metal screws, and then it went to PEEK screws, and then composite screws that left these big Goomba cysts in there sometimes.
Right.
And now what I do is there's an Arthrex technique that's called graft link that I've done for years now. And it's very nice because it's an allograft, but it's quadruple band allograft, nice and thick, and it has a suspension system essentially, so I can kind of customize the fit and tension of it on the femoral and the tibial side, which I think is fairly unique.
That is unique. I mean, I use an endo button on the femoral side.
Yeah.
I typically use the tibialis anterior. What do you take?
That's what it is. It's quad tip. It's 4 bundled over tibialis. It's pre-prepared, and it comes thawed, and they actually measure. They essentially take the X-ray of the patient and the height, and they measure, and they give me kind of a customized length.
Now that's new. I don't know much about that. So can you expand on that a little bit?
It's nice because you're in there and you drill these tunnels, and I actually had this happen once recently. Actually, it was mismeasured. I'm in there, drill my tunnel, and they're retrograde drilled. There's a thing called the Arthrex flip cutter, which is really nice. So you drill it in, you flip it to 10 millimeters, and you pull back, and it drills the tunnel from the inside out. So there's no large incisions. And then you insert the graft, and there's an endo button on the femur, but there's a cinching system that can tension the graft. And so my point is, I drilled these tunnels, I put this graft in, and the graft bottomed out on both sides.
Really?
And it was not fully tensioned. It was a smaller person, to be fair. And so what I had to do was I actually got the graft out of one of the tunnels. I thought of this on my own. This is what you have to do, right?
Right.
How am I going to tension this? You could take a blader and kind of shrink it, but you're going to mess up the collagen fibers. So I took the end out of the tibia, which was easier, and I actually twisted it 3 times intra-articularly, and then got it back in the femur and tensioned it, and it worked.
Wow.
Yeah. So by twisting it 3 times, I gained like a centimeter. It shortened like a centimeter.
Right.
Right. So it had great tension, and I was able to tension it, and so that worked.
That's fascinating. I'm very interested in that. Do you do a notchplasty?
Minimal, but yes, minimal.
Okay.
I used to do big ones.
Yeah, mine have become less over time
Right.
as well.
Right. Yeah, exactly. I still do that a little bit to flatten it and make sure I can see well, and I do think there's something to be said about the bleeding as well.
Yeah.
Yeah.
No, I would agree with that. So any other areas of your practice that you want to expand upon? Because, I mean, you got a practice that most guys would, die for. I mean, this is an envious practice that you have.
I appreciate that.
Yeah.
It's just like you mentioned, my doing this for so long now, I want it to be, fairly stress-free.
Yeah.
Like,
yeah.
I recently, not recently, maybe 8 or 9 years ago, I stopped doing shoulder replacements. And I used to enjoy them, but it wasn't something I learned how to do in my fellowship.
Right.
Right. And I used to do one a month, maybe. It wasn't like high volume. And just like you, I would have one on my schedule, and I would just dread it.
Mm-hmm.
And I would dread it, and then when I was done, it was a really great feeling.
You're kind of euphoric.
You are, and then I'd be like, oh, maybe I'll keep doing it. And then the patients, for the most part, did very, very well. And we're like, oh, I don't want to stop doing this. But one of the newer partners that we hired was fellowship trained, upper extremity only, and he was doing reverses, which I was not doing, and he was doing revisions. And I was like, you know what? He can have it. I'm going to stop doing it.
Yeah.
Just to be less stress.
Yeah. I stopped doing reverses for that exact same reason. I mean, it was a case that I worried about the whole week, and then afterwards I was like on cloud 9. But it's like I don't need that stress in my life anymore. Unfortunately, I'm not part of a big group like you, and so I have to send them away. And the problem with that is for me, I have to send them to the university and then they're gone forever.
Well,
They
that's
never come back. Yeah.
right.
So, but at least within your group is self-contained, and they're not going to take your patients away from you. I find your practice fascinating. Again, I think most guys would just be so envious of what you do and how you do it, and your exposure to the sports side of it, and maybe not the official team physician, but being there on the sidelines and in the locker room is something that guys just love to have. I've done it on a very minor level compared to what you do, but it is great fun
It is.
to do that. And I'll pick your brain a little bit about this. So I remember the first time where I was practicing at that time in Missouri, they'd never had a doctor on the sideline before. And so I show up, I'm on the sideline. Sure enough, the player goes down, and I'm like, am I supposed to go out there? Because everybody in the stands is watching you, and so I remember the first time I did it, I had the other players come around and kind of form a semicircle around the patient and I, so that the fans, couldn't see what it was I was doing. And I did that for my entire career, because every parent in the stands is watching what you're doing, and why are you doing that, and what's the outcome. And so that just kind of became a technique that I did. And also I think that the athlete appreciated it, because they're like center stage and everybody's staring at them. They don't like that.
No, and they're scared. They don't know what's going on, and it hurts. And, no, I totally agree. I think that's great. I think that's wonderful.
Yeah, it worked well.
Yeah.
I think that, again, I can't thank you enough for your time, Brian. I've learned a lot here today, and I know that the people that watch this podcast will learn a lot. I thank you for your time, your expertise. Is there anything else that you wanted to touch on? Because this has been very educational.
Thank you. No, very enjoyable. I enjoyed it very much. Be happy to join again if necessary on any subject.
I would love to have you back. I really would. So again, Dr. Brian Polsky from the Baltimore, Washington area, orthopedic surgeon, team doctor, and does something that a lot of us just don't know how to do, hip scopes, etc., with the rest of your sports medicine practice. So again, Dr. Polsky, thank you so much. I appreciate your time, your expertise, and I'm looking forward to talking with you again.
My pleasure. Thanks, Chris.
Thank you.
Healthcare Unscripted is powered by Fairwinds Medical, the commercialization team behind some of the most innovative technologies entering operating rooms today. With national reach and clinical expertise, Fairwinds moves new solutions from promising to practice. Visit fairwindsmedical.com to learn more.